Okay, everyone. Today we're going to be talking about the use of anti-inflammatory drugs. We're going to separate this in two uh, lectures also, one talking about non-steroidal and then the other one talking about steroidal anti-inflammatory drugs. So anti-inflammatory agents, as we have talked about how inflammation works. So inflammation is part of the immune system. The immune system is going to use inflammation, the inflammatory response, to mount up an immune response against any invading pathogen. There is going to be there's three phases for inflammation: the acute inflammation, the immune response, and sometimes we're going to have chronic inflammation continuing on. Different types of cytokines are going to be utilized. The acute inflammation is the initial response to the injury. We're going to have mediators being released and is going to precede the immune response. Some of the mediators are, histamine, prostaglandins. There is different one, leukotrienes. Chronic inflammation. The difference between the words chronic and acute means something of short duration. For example, something in the first 24 hours is acute, and something past 24 hours is considered chronic most of the time. But it's not necessarily 100% like that, because you can have a disease that was going to last 2-3 days and it's an acute form of the disease, but something that continues to last, such as a person that, or a horse that had influenza and has a lingering cough. So the influenza is the acute part of the disease, and then the lingering cough is like a chronic part of the disease. So this is the inflammatory cascade that we have. So the cell membranes are going to have phospholipids, and when so remember what we talked about in the immune response lectures, how the membranes, when they get broken, they're going to become activated, and in the presence of this enzyme called phospholipase, arachidonic acid is going to be released, is going to be formed. And then from arachidonic acid, there's going to be two pathways that the inflammatory cascade is going to work. And one is what we call the cyclooxygenase cascade, and the formation of prostaglandins is going to happen. And the other one is the lipoxygenase branch of that cascade, where leukotrienes are going to happen. So let's go and look at the right side of this cascade now. And we have the cell membranes, the phospholipids get interrupted, they get activated in the presence of phospholipase, an enzyme. Arachidonic acid is going to form. Arachidonic acid in the presence of cyclooxygenase, it's another enzyme, is going to form to prostaglandins, and then from prostaglandin G2, multiple other prostaglandins are going to form. Prostacyclin PGI2 is a type of prostaglandin, and this is going to cause vasodilation. Remember, we talked about inflammation, the 5 cardinal signs of inflammation is going to be redness, heat, pain, edema, and loss of function. So swelling and loss of function. So this is going to cause the vasodilation, this particular prostaglandin, and also it's going to inhibit platelet aggregation. So the blood is going to become more fluidy, because the platelets are not, there's no thrombosis being formed, there's no leaking, no clot being formed. Thromboxane A2, on the other hand, is going to cause vasoconstriction and is going to promote platelet aggregation. So in the first beginning of, say, a cut, this comes in very handy. And I don't know why this thing does this. This comes in, oh my goodness, comes in very handy, because you need an initial vasoconstriction in the area to stop the bleeding, and you need clot to form so the bleeding can stop. So thromboxane A2 is going to lead to bronchoconstriction and then promote platelet aggregation. But then the second phase of that initial inflammatory response, you're going to need vasodilation, so more blood can come to the area, and that the more blood in the area needs to also come and not be clotted, so you can bring healing to the area, and you're going to have the vasodilation happening. That's when you're going to have the leaking vessels and fluid is going to extravasate to the tissue, and the blood in that area is going to become a little bit more viscous, but no clot forming in the area. The blood is a little bit more viscous, then, so more white blood cells have contact with the wall of the blood vessels to be able to extravasate and go towards the tissue. Okay, there's other prostaglandins formed as well, and they are all what we call eicosanoids. These eicosanoids are pro and anti-inflammatory, so there is all of them being formed at the same time. And then the other branch of, well, what I had to say is that any kind of non-steroidal anti-inflammatory drug is going to block this enzyme from forming. So ibuprofen, naproxen, in the case of horses, Benamine or Bute, they're going to work exactly here, preventing cyclooxygenase from causing arachidonic acid to form prostaglandins. So these prostaglandins are not going to be formed. And that's how these things are going to help with pain and the inflammation that is happening in the area. The other side of the cascade is the lipoxygenase cascade, and this is going to form leukotrienes, and all these leukotrienes, they're going to, a lot of them are going to cause bronchospasm. Okay, there's going to be increased permeability in these blood vessels. There's vasoconstriction happening. So you guys can see how this is not even, this side here of the cascade is not even talking about lungs, okay? And this one here is. So it's just important that for you guys to understand that this side here of the cascade does not, when you take ibuprofen or naproxen and you have, like, say, an asthma attack, it does nothing to do for your bronchospasm, because this side of the cascade is not even mentioning lungs, okay? Now, it's important for also us to know that steroidal anti-inflammatory drugs are going to inhibit the very beginning of this inflammatory cascade. And this very beginning of the inflammatory cascade is going, so that's, you can see it's much more potent because it impedes absolutely everything. So because this inflammation is totally going to be impeded, it's not going to be allowed to happen, you don't have a lot of the times the healing that is necessary, because there is no healing if you don't have inflammation. So the healing that is necessary to actually cause the healing, the inflammation that's necessary to cause the healing, because in the use of steroids. The other thing too is that you need the inflammation. The inflammation is part of where the to recruit the adaptive immune system, and that's why a lot of the time steroids are going to block that as well. So for people that have like autoimmune diseases or anything that is allergic in nature, an overreactive immune system, that's why those people, those horses are put on steroid or anti-inflammatory drugs to try to prevent the activation of the immune system. So the eicosanoids are going to have effect in different areas of the body. So in the musculature of the vessels, they're going to cause either vasodilation or vasoconstriction. In the GI tract, they may cause, eicosanoids are what I've talked about, mediators, prostaglandins, etc. They are going to cause contraction. In the GI tract, they may lead to colic, they may lead to pain. In the uterus, they're going to cause contraction. In the pulmonary, in the respiratory system, they're going to cause bronchoconstriction. So all these eicosanoids, which can be the prostaglandins or the leukotrienes, are going to have effect on musculature, on the muscles. I'm sure that this is what it says. Yeah. Okay. So then we have non-steroidal anti-inflammatory drug. And the reason for the name non-steroids is because they're not steroidal. Steroidal anti-inflammatory drugs, as I said, is going to block the entire cascade. And they have their name because they mimic steroids, which is natural occurring hormones that we have. Okay, so we're going to talk about them in the next lecture. So they are different from the steroids. The main activity of these non-steroidal anti-inflammatory drugs is the inhibition of prostaglandins. During the treatment, inflammation is going to be reduced by decreasing the release of these mediators from the granulocytes, the basophils, mast cells, etc. So the whole side of cascade is going to be impeded, and that's why inflammation is going to be reduced. This is important, guys, and I want you guys to write a star beside this bullet point here, because all non-steroidal anti-inflammatory drugs are analgesic, meaning they decrease the pain. So they are not painkillers. Painkillers such as like, I don't know, hydroxycodone or codeine or morphine or Dolantin, those painkillers, they work in the brain. Okay, there is a receptor in the brain called the mu receptor, mu, like as that Greek letter. The mu receptor in the brain, when they get activated, causes pain. So painkillers actually have nothing to do with inflammation. They don't do anything for the inflammation. So that's why it's good after surgery to have the painkillers, because you don't feel any pain, but the inflammatory process is allowed to continue to happen to actually bring healing to the area. There is no healing that is going to be brought to the area without inflammation. But analgesia is a diminish of this pain. Remember 5 classic signs of inflammation. Pain is one of them. So there's going to be a little bit less pain. They're all anti-inflammatory. They're all antipyretic, meaning they reduce fever. They're all anti-endotoxic. We're going to see here by the end of this class, we're going to talk about this disease called endotoxemia, where endotoxins are released in the blood. And so, for example, Benamine is the #1 drug of choice to try to combat endotoxic shock, endotoxemia. And so they bind to these endotoxins. It's something that is released by bacteria, gram-negative bacteria. And they are all antithrombotic. They all inhibit platelet aggregation, okay? This is important to also know that they are all gastric irritants. The reason for that is because one of the prostaglandins is actually responsible for the formation and release of and secretion of mucus inside the stomach. And once we block the prostaglandins, we're blocking every prostaglandin. And that's how, because now the mucus is not going to be formed in the stomach. So this acid is going to be in straight contact with the stomach wall, and it's going to possibly lead to the formation of gastric ulcer. So they're all gastric irritants, and they all can cause kidney problems. So that's why there is like a time that you can give this NSAIDs to these horses, and there's times that you can't. If he's going to have to be on long-term duration for the treatment, you sometimes have to measure kidney function to be able to see if the horse is not having kidney failure. NSAIDs used in horses, there is more, but these are the ones that are regularly used all the time. Benamine and bute is the most widely used. We also can use ketoprofen, naproxen. Firocoxib is called Equiox, and it's one that is a COX-2 inhibitor, so it causes less stomach problems and less side effects, such as kidney problems. Also, aspirin. Aspirin is a very, it's a more weak kind of anti-inflammatory drug. It has doses in which it has the effect. So the lowest dose it causes, it prevents platelet aggregation. The second higher dose, it is going to decrease fever and cause a little bit of analgesia. And then the third high dose, it is actually going to be anti-inflammatory. So it's used generally, aspirin in horses is used to increase circulation, like in the lower limbs, because it makes the blood a little bit more fluidy. And then dipyrone is used in cases of colic all the time. Benamine is something that is important for everyone to be able to administer to horses. If you don't know how to administer an IV of Benamine to a horse, you need to ask a veterinarian to help you, because there is emergencies that you need to be able to administer Benamine to the horse via IV as opposed to giving orally, because there's only so much you can give a day to a horse. And if you already gave that amount orally and the horse has, for example, colic, and one of the ideas of, are we going to take this horse to surgery, is how he responds to Benamine. And if you already gave oral Benamine, it's going to take 2-3 hours to have a full effect. And the veterinarian is coming and is impeded to give IV Benamine, which is how we measure the response of the horse to Benamine. So it becomes a little bit of a problem. So you have to learn to give Benamine IV to these horses. Okay, so what are the uses of these non-steroidal anti-inflammatory drugs? So like I said, they're all analgesic. So the number one use is to relieve pain, to provide analgesia. And obviously, like I said, the eicosanoids are going to be causing pain as one of the reasons for the inflammatory. The 5 cardinal signs, one of being pain, is these eicosanoids causing pain, and the non-steroidal are going to help with that. To reduce fever, like I said, and fever is a natural, if you guys remember from the immune response lecture, the fever is a natural response of the body to increase its temperature to try to kill these invading microbes. But sometimes fever, if out of control, can be very deleterious to the body. Just as to give you an example, high fever, the brain is pretty much made of fat, tissue. And if you guys think about like what happens to butter, which is a semi-solid fat, when you add heat to it, what happens to it? It melts. So, and that's what happens with animals or people that have high fever for prolonged periods of time. The brain starts to degenerate and the brain starts literally to melt. And that's when people have neurologic problems for the rest of their lives because of high fevers that they may have had when they were kids. So like, that's why I say here, while fever is a natural mechanism for the body to kill these invading microbes, it can cause irreversible brain damage. So it's very important to control the fever. And like I said, in humans, it's controlled with ibuprofen or Tylenol. In horses, Benamine is a drug of choice for that. Counteracting endotoxemia. We're going to study endotoxemia later on, more towards the end of this class. And it's when this bacteria, more specifically gram-negative bacteria, release these endotoxins upon their death or upon their multiplication. And these can be life-threatening. They cause very severe problems with the cardiovascular system. They cause disseminated intravascular coagulopathies. They cause a lot of problems. And Benamine is the drug of choice to, as an NSAID, to prevent that, or to actually be anti-endotoxic. So it doesn't prevent, it just binds to the toxins. And to reduce excessive blood clotting by blocking the thromboxane A2. These NSAIDs are going to be able to help maintain blood flow and perfusion to areas. So, like I said, like for example, endotoxemia causes disseminated intravascular coagulopathies, where you're going to have blood clotting everywhere and decreasing the perfusion in certain organs, in whatever organ that you have a blood clot in. And these Benamine, for example, remember when and even low dose aspirin, but Benamine is the drug of choice to use for that, is going to combat that. So it's going to maintain blood flow in situations where this excessive blood clotting may be causing a problem. Okay, so these are the uses of these particular drugs. Phenylbutazone, it's IV. It's you can give via oral in as a paste or as tabs. Benamine, it's IV, and you can also give it as a paste. Some people just going back to Benamine, which I guess is the next one, but some people give Benamine, the IV formulation, in the mouth of the horse. And for those that do that, and I said you have to learn to give an IV Benamine, I just challenge you to actually try a drop of Benamine so you can see how nasty the taste is, and horses actually hate it. So once you do that yourself, and you're going to see how nasty it is, you're never going to be able to do that to your horse again. So there is a formulation which is a paste, and if you're not going to learn to give an IV, don't do the IV medication orally. But bute is very potent in pain as a pain reliever. Anti-inflammatory, antipyretic. It is very, very commonly used for lameness. Any lameness that come from soft tissue injury or muscle pain or even bone and joint problems, it is very, 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 very widely used. And generally, the tabs are super, super cheap. It can be given intravenously or orally. So when it's given intravenously, it's like, for example, when the veterinarian comes to do a joint injection, he's going to leave, or anytime the horse has some sort of surgery, he's going to have bute given intravenously. The pain relief is going to start acting when given orally within an hour or two. IV, it's a little bit faster, as is with everything that we give IV as opposed to orally. And if the horse is going to need bute for more than a few days, I think the research shows about 12 days is the max, but we generally just go max to about 6 days, as 2 grams for the first 3 days and then 1 gram for the next few days. But if the horse is going to need more than like a week of bute, it's important to also give some sort of GI tract protectant, such as omeprazole, ranitidine, or cimetidine. It's important because it is very, very highly, it can cause gastric ulcerations. Flunixin meglumine, which is Benamine, number 1 for the treatment of colic. It also is number 1 for the treatment of endotoxin shock. And it is for the eye. For some reason, Benamine is also the number 1 non-steroidal anti-inflammatory drug for pain that comes from the eye. I think it's important that I mention that any problem that the horse has in the eye is an emergency. The eye of the horse can deteriorate really, really quickly. And if the horse has any kind of inflammation, cloudiness, or swelling on the eye, it is an emergency. A veterinarian needs to be called, because the horse can lose sight and lose its eyesight very, very quickly. So it is always an emergency. But Benamine, in the case of like corneal ulcers, uveitis, conjunctivitis, before and after eye surgery, is the drug of choice. Can be used also to control fevers. It can be given IV or orally. So in the Benamine label, it says that it can be given IM, but upon when the use of Benamine was approved by the FDA a million years ago, I guess the studies were not done to perfection. The truth is, Benamine cannot be given intramuscularly. It causes this thing that I'm going to show in the next slide, that is a clostridial myositis, that it putrefies wherever you're going to give that injection, which is generally on the neck of the horse. And it causes, obviously, like I said, if you're going to use for a few more than just a couple of days, you need to be able to help the horse with omeprazole. So this is clostridial myositis right here. Clostridium, any kind of Clostridium bacteria, is an anaerobic bacteria that can be very, very deadly. So if you guys are going to learn about Clostridium tetani, which is the causative agent for tetanus, Clostridium botulinum, which is the causative agent for botulism, these 2 bacteria are extremely deadly. Other types of Clostridium bacteria are Clostridium difficile and Clostridium perfringens, and they can cause severe enteritis, diarrhea. And in this case here, they thrive in the absence of oxygen. They are all anaerobic. In this case, when Benamine was given in the muscle of the horse, this particular bacteria, which live in the environment, get introduced into the muscle, and in that presence, or in that absence of oxygen, they just start to multiply, and they form gigantic areas of gas. So you have to lance the muscle of the horse wherever you find this gas formation, these pockets of gas, and you have to tie, if you guys can see here, these areas open, okay? So the gas that is being formed continues to be released. This, in the end of it all, sometimes the horse loses the entire skin over here. It's nasty. It is very nasty. Don't ever give Benamine in the muscle to a horse. And like I said, you need to learn to give it IV. And if you can't, you have to learn from your veterinarian. So here's where we're going to end with non-steroidal anti-inflammatory drugs. In the next lecture, we're going to be talking about steroidal anti-inflammatory drugs.